everyone. Welcome to today's Exploring Best Practices related to the ABCS of Heart Health, a structured collaborative. This is session 3 on aspirin use and cholesterol management. I'd like to start with asking, first of all, Carrie has put the pre-evaluation link in the chat. So if you all could take a few minutes to answer that as we are getting started. And then I will kind of go through some of the housekeeping items here. If everyone could please update your name in your Hollywood Square to include both your name and your organization you're part of. It's hugely helpful to us as we are tracking with people, and it helps for everyone to make connections and get to know one another. If you don't know how to do this, you can just click on the ellipsis in your Hollywood Square or click on your name in your Hollywood Square. You can right click on your name and you can say rename. And that will allow you to add your organization next to your first and last name. I am going to do that right now. And then if everyone could also please add for introductions, add into the chat your name, your title, your clinic organization, and your location. If there are more people with you on Zoom, on your Zoom line than just you, please put everyone's name in the chat. Again, this helps us to get to know one another. And then we'd also like you to add what was one thing from the first or the second session in February and March that you were able to try or put into practice this last month. And while you all are doing those few things, then I just have a couple more things I'd like to go through and remind you of. All sessions will be recorded. We hope you're able to attend each session, but if not, we'll send out the recording each month. And while we do want everyone to mute yourself when you are not speaking, we do also want this session to be interactive. So please feel free to jump in at any point if you have a question or a comment, or you can also add that to chat. And then lastly, we'd like to see your smiling faces. So please turn on your cameras. Again, as a reminder, the things that we discussed at the last couple of sessions are some of those things are on the slide here. And we're just hoping that you can add something to the chat about something that maybe you learned or that you're putting into place, such as identifying a champion or how to appropriately use the CPT codes to achieve a positive return on investment. Our schedule for the rest of the collaborative is in May and June. Remember, these are on the first Tuesday of the month, and they happen from noon to 1 Central Time or 1 to 2 Eastern Time. On May 7th, we're going to be talking about tobacco cessation. And on June 4th, we're going to be talking about cardio rehab. So again, as I said earlier, this session is on aspirin use and cholesterol management. I'm going to quickly run through our objectives for this session, and then I'm going to turn it over to my colleague, Jerry Hineker, who will be talking about aspirin use. So our objectives for aspirin use are understanding the role of aspirin in cardiovascular health and identifying appropriate candidates for aspirin therapy and educating patients on the use of shared decision-making. Later, I will be talking about cholesterol management, and our objectives for this will be understanding the role of cholesterol and cholesterol management in cardiovascular health, identifying risk factors for high cholesterol, and educating patients on lifestyle modifications for cholesterol management. And with that, Jerry, I will turn the floor over to you.
Thanks, Nicole. And we're going to start out, as Nicole said, with aspirin use, or the A that's part of the ABCS of heart health that this whole collaborative is about. We talked about blood pressure in our first 2 sessions. Then Nicole is going to do the C, the cholesterol today also, and then we'll hit smoking or tobacco use next month. And I want to start out with saying that some, or maybe even for some of you, most of what you hear today is maybe not going to be new information. You might already know everything we're going to talk about. So just wanted to put that out there in case this isn't a lot of new information for you. But what we really are trying to do with these sessions is to get everybody on the same page so that everybody has the same information. Also, a lot of what we're covering today and these slides that we're using, we're hoping that you can then use them in patient education. So when you're teaching your patients so that you find them useful for that. Next slide, please, Nicole. So today, as we're discussing aspirin use, we're talking about aspirin use as part of primary and secondary prevention. So for primary prevention, what we're talking about, the primary prevention is really aimed at preventing disease or injury before it occurs. So aspirin use in that sense. And this is something when we talk about aspirin, what we'll get further into the presentation today is, can we use aspirin to prevent cardiovascular disease or prevent strokes or heart attacks? And then also we're talking about secondary prevention. So using aspirin in secondary prevention. And so in secondary prevention, we're trying to reduce the impact of a disease or an injury. So maybe you already have cardiovascular disease. How can we use aspirin to halt the progress or progression of that disease, or again, halt effects of cardiovascular disease, such as a heart attack or stroke? Well, we're not talking about it today. We all know that aspirin also plays a role in the treatment of acute cases of such as myocardial infarction or even maybe stroke. So we're not covering that today, but just wanted to kind of clarify what the presentation is really looking at today. So again, the mechanism of action for aspirin, which is how we got here for aspirin as part of primary and secondary prevention, is aspirin reduces the platelet aggregation and thrombus formation. So while the reason we used it in primary prevention is that, because of this action, it was thought that a daily aspirin could possibly prevent heart attack and stroke. And then again, in secondary prevention, because it inhibits platelet aggregation, it's the thought that we're reducing that risk for recurrent arterial thrombosis. And that is why it was used or is used in secondary prevention of cardiovascular disease. Next slide, please. So I want to talk a little bit again about starting with primary prevention. So the evolution of why we use aspirin in primary prevention of cardiovascular disease. So aspirin's antithrombic effects, it has a long established place in prevention of cardiovascular disease. And it's been traditionally used as a core therapy for secondary prevention of CVD now. But with the advent of new antiplatelet agents and then an increasing understanding of aspirin's bleeding risks, the role of aspirin in CVD prevention has kind of come full spectrum, and how we're going to use it even in the future has become less certain. So really, aspirin as part of primary prevention was initially motivated by this antithrombotic successes in trials. And then some of those major trials were first published or first conducted from 1988 to 2001. And so in these trials, we saw a reduction in heart attack and stroke. And then so we thought, okay, aspirin, this is great. And not that aspirin isn't a great drug, but that is why we first started using aspirin in primary prevention. And then so we were thinking that it could help prevent those fatal heart attacks and lower mortality overall if you have cardiovascular disease risk. Next slide, please. I'm continuing just a little bit here too on the evolution of the use of aspirin in primary prevention. So we had those initial trials where, it's like and I think we all saw everybody take an aspirin, take an aspirin. Then in 2018, there was 3 separate trials that were conducted. The aspirin to reduce risk of initial vascular events, or the ARRIVE trial. I love these names. The ASCEND trial, which is a study of cardiovascular events in diabetes. And then there was the ASPRI trial, or aspirin in reducing events in the elderly. So these 3 trials occurred in 2018 because they were starting to kind of question the use of aspirin as being used in primary prevention. In all of these trials, in some way, shape, or form, their conclusions were that there was no significant difference in the first occurrence of a heart attack or stroke, or in death from cardiovascular disease, between the study group, those taking aspirin on a daily basis, a low dose aspirin, or in the control groups. And then there was another study published in 2020. This was the International Polycap Study 3, or the TIPS 3 study. And this study really kind of focused a little bit more on women who were over the age of 60 or older, and men who were 55 or older without heart disease or known heart disease, or those who had not had a prior stroke or a prior heart attack. And again, the conclusion of this study was, as part of primary prevention, a low dose of aspirin, again, did not show any difference in death, at least for cardiovascular disease, or the occurrence of heart attack or stroke. So why are we seeing this big change? We had these initial studies done, in the 80s, 90s, early 2000s, that really, again, touting everybody needs, not everybody, but people should be taking aspirin who met the criteria. And now we're not seeing this as part of primary prevention. And really, one of the main theories that we're seeing is, first of all, and we'll talk a little bit more about this, there's other drugs that have been discovered that can be used for their antiplatelet qualities. And then also, we're kind of thinking, a lot of what we're seeing is that when a lot of these studies were done in the 80s or 90s, as far as cholesterol control, there weren't a lot of drugs. I mean, I remember my dad, he was told, eat a low cholesterol diet when he was told he had, high cholesterol. There weren't a lot of drugs being given as as cholesterol management drugs. Now we've got the statins, and what we're seeing is better control through drugs such as statins has reduced the incidence or better managed cardiovascular disease. Thereby, do we really need to do this daily aspirin therapy, which has, some complications or some risk factors for certain people, especially the bleeding risks. Next slide, please. So that was the evolution of primary prevention. I'm going to talk a little bit here too about, where we've kind of been and are going with the continued use of low dose aspirin in secondary prevention. So again, as part of secondary prevention, so again, patients who already have been diagnosed with cardiovascular disease or might have some type of, had a heart attack. So as part of the international guidelines, there was that recommendation for a lifelong low-dose aspirin as secondary prevention, as I said, for those who have cardiovascular disease. But as I mentioned before, we're seeing other newer and more potent antiplatelet drugs, such as the P2Y inhibitors, and this is like Plavix. And then also there's other antithrombotic options for secondary prevention besides aspirin. So that's why, again, we're not seeing even aspirin as much for secondary prevention. Next slide, please. I do just want to go a little bit over some of these, primary prevention recommendations. There is the possibility, again, we want to make sure that you're aware of and using the guidelines in your facility. But there may be some instances where a low dose aspirin, and we're talking 75 to 100 milligrams, basically your baby aspirin, may be recommended. Again, just incidents where it might be recommended for primary prevention of heart attack or stroke. And these are in a select group of adults. Usually we're looking at the ages of 40 through 70, and they're at higher risk for, I'm just going to say ASCVD. I cannot say atherosclerotic cardiovascular disease very well. I apologize. But again, you have to look at those patients who do not have an increased bleeding risk. And then again, select patients under the age of 60 who have diabetes, and they may have one other risk factor, at least one other risk factor, such as they're a smoker or they have high blood pressure. But really, overall, the U.S. Preventive Task Force recommends against initiating low-dose aspirin therapy in most cases for any patients over the age of 60 as primary prevention for ASCVD. So next slide, please. Aspirin as part of secondary prevention. Again, we've got some recommendations here. So as part of secondary prevention, a daily low-dose aspirin may be recommended for prevention of heart attack or stroke for patients who have that diagnosis of ASCVD, or they already have an existing heart problem or a history of, maybe they've had a heart attack or they've had stroke, they've had angioplasty, percutaneous coronary intervention or a CABG done. These may be patients that would benefit from a low-dose aspirin as part of secondary prevention. Again, follow your organization's guidelines. It's going to be all based, these are based on clinical judgment for the patients. You need to consider everything about the patient and their history when you're prescribing low-dose aspirin as long-term antiplatelet therapy. Next slide, please. So how do we identify who might be an appropriate candidate for aspirin therapy? You really need to take a look at the patient as a whole and do a patient risk assessment. And again, what is the protocol that your facility is using for this when you're managing your patients with CVDs? So do they have a history of a cardiovascular event? Also, what are their other risk factors? So is this an elderly patient or a patient who's at risk for falls? They're probably not going to be a good candidate for aspirin because of the potential for bleeding risk. Also, patients who are using alcohol, again, there's contraindications for a daily aspirin for them. Do they have any drug interactions if you're going to be putting them on aspirin? Also look at kind of their family or look at their family and social history. And you just really need to kind of balance those benefits and risks overall if you're going to be prescribing aspirin. You know, do they have bleeding, do they have a bleeding ulcer? Do they have gastrointestinal disease or bleeding risk in that area? Also, do they have allergic reactions? Do they have aspirin-induced asthma? Those are patients, of course, who would not be a candidate for aspirin use. Next slide, please. And I just want to wrap up this section talking about educating your patient and using shared decision-making when you're deciding if a patient is someone who should be put on aspirin therapy. We're going to talk more again about patient education overall at the end of our presentation today, but just going to hit a little bit on it here when we're talking about aspirin. It's really important when you're doing a treatment plan for a patient. You want to make sure that your patient, their caregiver, their family, who's ever, their support system, that they're involved in that decision. They really need to be part of that decision or shared decision making. Like any of us, when we're part of the decision and we understand why we're doing something, much better outcomes as far as them maintaining or following through with the therapy. And it's also very important that they understand the benefits and the risks. Encourage them to ask questions. You don't want them to feel like they're just being lectured to. I'm sure that's not what you do, but sometimes you kind of have to draw the questions out of the patients because, sometimes patients, they don't want to ask questions. So make sure, you encourage them to ask their questions. This is also a good time to use like a teach back method, so after you've gone through the information and they haven't maybe asked you questions, ask them to tell you back what it was that they just learned so that they understand, and maybe that's when they'll ask their questions or state their concerns. Again, just make sure that they're comfortable in this situation with the teaching and that they understand it's okay to ask questions or express concerns. And again, it's part of this treatment it's their decision too. That's why we call it shared decision making. And make sure that they have a means after they get home, if they can ask questions, because I know that's for me. Once I get home, that's when I think of all my questions. So make sure that they understand if something comes up after they're home, they're free to, get back to you with questions about their therapy. So that is all I have. I'm going to turn it over to Nicole now.
Thanks, Jerry. What a great section. Thank you for all your work on that, and thanks for educating us. So now we're going to move on and talk a little bit about cholesterol management. And I'm going to reiterate what Jerry had to say about that. I realize a lot of this is not going to be new information for you all. It really is more of an overview, but we also think that you'll be able to use these slides when you're talking to your patients and helping to educate your patients in an effective way. So, okay, so what is cholesterol? Well, we may associate cholesterol with fatty foods, but really most of the waxy substance in our system is made up of our own bodies. The liver produces 75% of the cholesterol that circulates in our blood, and the other 25% comes from food. Cholesterol is a type of lipid fat that's essential for building cells and producing certain hormones in the body. It's a waxy fat-like substance that is found in all cells of the body and is also present in the bloodstream. Cholesterol plays several important roles in the body, including cell membrane structure. Cholesterol is a major component of cell membranes, providing structure and stability to the cells. It helps maintain membrane fluidity and allows cells to function properly. Hormone production. Cholesterol is a precursor for important hormones like cortisol, aldosterone, estrogen, progesterone, and testosterone. These hormones are essential for metabolism, stress response, fluid balance, and reproductive functions. Bile acid synthesis. Cholesterol is crucial for making bile acids in the liver. Bile acids help digest fats and absorb fat-like soluble vitamins into the small intestine, ensuring proper nutrient absorption and digestive health. And then vitamin D synthesis. Cholesterol in the skin is converted into vitamin D when exposed to sunlight. This vitamin is crucial for bone health, immune function, and calcium metabolism. While cholesterol is vital for various physiological functions, it is important to maintain a balance of cholesterol levels in the body. High levels of low-density lipoprotein, LDL cholesterol, often referred to as bad or lethal with the L, can contribute to the development of cardiovascular diseases. And on the other hand, high-density lipoprotein, HDL, or healthy cholesterol, known as also good cholesterol, helps remove excess cholesterol from the bloodstream and reduces the risk of cardiovascular disease. Therefore, maintaining healthy cholesterol levels along with adopting a healthy lifestyle is crucial for overall health and well-being. This includes eating a balanced diet, low in saturated fats and cholesterol, and engaging in regular physical activity, maintaining a healthy weight, avoiding smoking, and managing other risk factors for heart disease. LDL, low-density lipoprotein. We just talked about this a little bit. The L stands for lethal. That's sort of a way that we can help remember it. Or some people also call it bad cholesterol. There are different types of lipids. Whoops, sorry here. And then HDL, high density lipoprotein, and triglycerides are different types of lipid fats present in the bloodstream. They can play distinct roles in the body and have varying effects on cardiovascular health. LDL, low density lipoprotein, often referred to as the bad or the lethal cholesterol. The main function here is to transport cholesterol from the liver to the cells throughout the body. High levels of lipoprotein in cholesterol can lead to the buildup of plaque in the arteries. increasing the risk of heart disease and stroke. The optimal LDL cholesterol levels are generally considered to be less than 100 milligrams. High-density lipoprotein, HDL, often referred to as good or healthy cholesterol. The main function here is to transport excess cholesterol from the cells back to the liver for disposal. High levels of HDL cholesterol are associated with reduced risk of heart disease because it helps remove cholesterol from the bloodstream. Optimal HDL cholesterol levels are generally considered to be 40 milligrams or higher for men and 50 milligrams or higher for women. Triglycerides. Triglycerides are a type of fat stored in the fat cells and released for energy when needed. They are derived from the fats that we eat and also produced by the liver. Elevated triglyceride levels can be caused by factors such as obesity, physical inactivity, excessive alcohol consumption, and diets high in carbohydrates and sugar. High triglyceride levels are associated with an increased risk of heart disease, especially when combined with low HDL cholesterol and high LDL cholesterol levels. Optimal triglyceride levels are generally considered to be less than 150 milligrams. Total cholesterol refers to the overall amount of cholesterol present in a person's blood. It includes several types of cholesterol, primarily LDL, HDL, and triglycerides. When healthcare providers measure total cholesterol, they typically consider the levels of LDL cholesterol, HDL cholesterol, and sometimes triglycerides to assess a person's overall cardiovascular risk. High total cholesterol levels, especially when accompanied by high LDL cholesterol levels or triglyceride levels and low HDL cholesterol levels, can increase the risk of developing heart disease and other cardiovascular conditions. In summary, LDL cholesterol is considered harmful as it can contribute to plaque buildup in arteries, while HDL cholesterol is beneficial as it removes excess cholesterol. Triglycerides are a type of fat that, when elevated, can also increase the risk of cardiovascular disease. Optimal levels of LDL and HDL cholesterol and triglycerides are important for maintaining heart health. Overall, the moral of understanding LDL and HDL and triglycerides is to emphasize the importance of balanced lipid levels and proactive management to reduce the risk of heart disease, stroke, and other cardiovascular complications. It highlights the significance of lifestyle choices and medical interventions in maintaining optimal cardiovascular health. Sorry, I'm getting a little tongue-tied. Current cholesterol testing and guidance are shaped by organizations like the American Heart Association, the American College of Cardiology, and the National Lipid Association. Recommendations may vary on individual risk factors. Here's some guidelines regarding that. Adults 20 and above should have a cholesterol screening every 4 to 6 years for cardiovascular risk assessment. Those with heart disease risk factors may need more frequent screenings. A standard lipid panel includes total cholesterol, LDL, and HDL, and triglycerides, with additional tests sometimes recommended. LDL cholesterol goals vary based on risk. A very high risk equals low LDL below 70. A high risk is LDL below 100, and a moderate risk is LDL below 130. Follow-up testing is advised after starting or adjusting lipid-lowering therapy, and then periodically based on risk and treatment plan. Special populations like diabetes patients may require more frequent monitoring. Individualized plans based on patient factors are crucial, and patients should consult their healthcare providers for personalized guidance. Now we're going to talk a little bit about risk factors that are both within our control and outside of our control. Risk factors for high cholesterol that are not within a person's control involve understanding factors that are predominantly influenced by genetics and/or other modifiable aspects. Here are some of the key, here are some of the key risk factors for high cholesterol that are beyond an individual's control. So genetic factors heavily influence cholesterol levels. A family history of high cholesterol or early heart disease suggests a genetic link. Cholesterol levels rise with age, especially LDL cholesterol. Men generally have higher levels than premenopausal women, but postmenopausal women may also experience elevated LDL levels. Some ethnic and racial groups may have higher prevalence of high cholesterol and related cardiovascular risk factors. For instance, African Americans and Hispanic Americans may have elevated LDL cholesterol levels compared to Caucasians. Hormonal changes, such as those occurring during puberty, pregnancy, and menopause, can influence cholesterol levels. Pregnancy, for instance, can lead to a temporary increase in cholesterol levels due to the support of the fetal development. Certain medical conditions that affect metabolism, hormone levels, or liver function can contribute to high cholesterol. These conditions may include hypothyroidism, underactive thyroid, chronic kidney disease, and liver diseases. Genetic lipid disorders can lead to elevated cholesterol levels. These conditions are caused by genetic mutations affecting lipid metabolism. Genetic variations in lipid metabolism genes affect cholesterol levels and are inherited. Though these factors can be controlled, awareness helps healthcare providers assess cardiovascular risk. Regular screenings, lifestyle changes, and targeted interventions based on genetic risk can reduce high cholesterol's impact and lower cardiovascular disease risk. And social determinants of health can also influence various aspects of an individual's life, including their access to resources, opportunities, and living conditions. Several factors related to SDOH can contribute to high cholesterol levels and consequently an increased risk of cardiovascular disease. So on our next slide, we're going to talk a little bit about the risk factors that are within a person's control. But I'm wondering if you all could enter in the chat what you think some of those are, and then we'll review. So if you all could just enter in the chat. Let's see, not monitoring or looking to monitor the chat. Can't find it on my screen here. Oh, here it is. Sorry. Okay, diet. April says diet. Thank you, April. That is definitely one of them. Anyone else? Exercise. Yep. Okay, well, we'll move on to the next screen here. So yeah, definitely risk factors for elevated cholesterol within our control. Identifying these risk factors that are within our control involves recognizing lifestyle and behavioral factors that can be modified or managed to improve cholesterol levels. So yes, consuming a diet high in saturated fats, trans fats, and dietary cholesterol can raise LDL, the bad or the lethal cholesterol levels. Examples of foods to limit or to avoid include red meat, full-fat dairy products, fried foods, and processed snacks. Lack of regular physical activity can contribute to high cholesterol levels and weight gain. Engaging in regular exercise, such as brisk walking, jogging, cycling, swimming, or aerobic activities, can help raise HDL, the good cholesterol, the healthy cholesterol, and improve overall cardiovascular health. Being overweight is associated with elevated LDL cholesterol levels and decreased HDL cholesterol levels. Losing excess weight can help improve cholesterol profiles and reduce cardiovascular risk. Tobacco damages blood vessels and accelerates the buildup of plaque in the arteries, leading to higher LDL cholesterol levels and increased cardiovascular risk. Quitting tobacco can have a positive impact on cholesterol levels and overall heart health. Excessive alcohol consumption can raise triglyceride levels and contribute to high cholesterol and poor cardiovascular health. Chronic stress and unhealthy coping mechanisms can lead to poor dietary choices, weight gain, and increased cholesterol levels. Insufficient sleep can also impact cholesterol metabolism and cardiovascular health. By focusing on these modifiable risk factors, making positive lifestyle changes, individuals can effectively manage high cholesterol levels, improve lipid profiles, and reduce the risk of cardiovascular disease. Regular cholesterol screenings and consultations with healthcare providers are also important for monitoring cholesterol levels and implementing personalized management plans. And finally, let's talk through some lifestyle modifications that can play a crucial role in managing cholesterol levels and promoting heart health. Here are some key lifestyle changes that can help in cholesterol management. Choose foods low in saturated fats, trans fats, and dietary cholesterol. Opt again for lean proteins such as poultry, fish, legumes, and tofu. Include plenty of fruits, vegetables, whole grains, and fiber-rich foods in your diet. Remember, eat the rainbow. Limit intake of red meat, processed meats, full-fat dairy products, and fried foods. Use healthy fats like olive oil, avocados, nuts, and seeds in moderation. Achieve and maintain a healthy weight through a combination of balanced diet and regular exercise. If overweight, focus on gradual, sustainable weight loss through diet and exercise, and even modest weight loss can improve cholesterol levels. Engage in aerobic exercises such as brisk walking, jogging, swimming, cycling, or dancing for at least 3 minutes most days of the week. Incorporate strength training exercises 2 to 3 times a week to build muscle mass and boost metabolism. Aim for a total of 150 minutes of moderate intensity exercise or 75 minutes of vigorous intensity exercise per week. If you use tobacco, quit to improve cholesterol levels and reduce the risk of cardiovascular disease. Seek support from your healthcare professionals, tobacco cessation programs, or counseling services. Drink alcohol in moderation, if at all. Limit intake to no more than 1 drink per day for women and up to 2 drinks per day for men. Avoid binge drinking and excessive alcohol consumption, as they can raise triglyceride levels and contribute to high cholesterol. Practice stress-reducing techniques such as mindfulness, meditation, deep breathing exercises, yoga, or engaging in hobbies and activities that you enjoy. Prioritize adequate sleep and establish a healthy sleep pattern to manage stress and support overall well-being. If prescribed cholesterol lowering medications, take them as directed by your healthcare provider. Schedule regular checkups and cholesterol screenings to monitor your cholesterol levels and cardiovascular health. By making these lifestyle modifications, you can effectively manage cholesterol levels, reduce the risk of heart disease, and improve overall heart health. It's essential to work closely with your patients to develop a personalized, tailored plan to help meet their needs and health goals. Next, we're going to explore some various medications used for managing high cholesterol: statins, bile acid sequestrants, niacin, fibrates, and injectable medications such as the PCSK9 inhibitors. They each play a role in lowering cholesterol levels through different mechanisms, and it's essential to understand the benefits and considerations of each medication when developing a treatment plan. Statin drugs lower LDL cholesterol by slowing down the liver's production of cholesterol. They also increase the liver's ability to remove LDL cholesterol that is already in the blood. Bile acid sequestrants help to remove cholesterol from the bloodstream by removing bile acids. The body needs bile acids and makes them by breaking down LDL cholesterol. Niacin is a vitamin B that can improve all, is a B vitamin, sorry, that can improve all lipoprotein levels. Nicotinic acid raises high-density lipoprotein cholesterol levels while lowering total cholesterol, LDL cholesterol, and triglyceride levels. Fibrates lower triglycerides through several complex mechanisms, including reducing triglyceride production in the liver. Injectable medicines called PCSK9 inhibitors lower cholesterol, increasing LDL receptors. This results in a decrease in LDL cholesterol circulating in the bloodstream. We do have a citation in the resource page at the end of this that provides further guidance on statin use for primary prevention and cardiovascular disease in adults. Current guidelines for medication usage in patients at risk of cardiovascular disease is as follows. For patients aged 40 to 75 years with one or more cardiovascular risk factors, such as dyslipidemia, diabetes, hypertension, or smoking, and an estimated 10-year CVD risk of 10% or greater, it's recommended to initiate a statin. For patients in the same age group, but with a 10-year CVD risk of 7.5% to less than 10%, the recommendation is to selectively offer a statin. For patients aged 76 years or older, the evidence is currently insufficient to recommend for or against starting a statin. Overall, based on available evidence, the use of moderate intensity statin therapy appears to be reasonable for primary prevention of CVD in most patients. So now that we've talked through what cholesterol is, risk factors, guidelines for testing, and medication, let's talk a little about the role of patient education and shared decision-making in cholesterol management. This is fundamental in empowering patients to make informed health choices and actively participate in their treatment journey. Patient education plays a vital role in helping individuals understand the significance of managing cholesterol levels. It involves providing information about cholesterol, its impact on health, lifestyle modifications, and available treatment options. Shared decision-making is a collaborative approach where healthcare providers and patients work together to make healthcare decisions. It considers patient preferences, values, and goals, leading to more personalized and effective treatment plans. Various tools and resources are available to facilitate patient engagement and shared decision-making. These include educational materials, decision aids, interactive sessions, and communication platforms that enhance patient to provider interactions. By prioritizing patient education and shared decision-making in cholesterol management, we can empower patients to take an active role in their health, improve treatment adherence, and achieve better health outcomes. But are they ready? The readiness to change model, also known as the trans-theoretical model or the TTM, is a model that provides a reliable framework for both self-change and professionally assisted change. offering benefits for individuals seeking change and healthcare professionals assisting with change. It's important to note that this model promotes a non-coercive approach, ensuring that changes are supported rather than pressured. We should aim to meet patients at their current stage of readiness and utilize motivational interviewing techniques to facilitate positive change. If you are not familiar or would like a refresher on motivational interviewing, please check out the link in the slides and on Connect. And maybe Carrie, would you be willing to put the motivational interviewing link from Connect into the chat? That would be great.
Yes, give me just a moment and I'll get that entered.
Thank you. So the readiness to change model, you see the model on the screen here, or the TTM. This outlines 6 key stages in the change process. Oh, go back one, sorry. Pre-contemplation. This stage reflects a lack of intention or readiness to take action regarding a behavior or change. Contemplation. Here, individuals are aware of the need for change and have intentions to take action, although they may not have committed to a specific step yet. Preparation. In this stage, there is a clear intention to take action, and individuals may have started taking initial steps towards that change. Action. At this point, individuals have actually actively changed their behavior for at least a short period of time. Maintenance. This stage signifies the long-term commitment to maintaining the changed behavior, ensuring it becomes a lasting part of one's lifestyle. And then termination. Finally, in the termination stage, individuals have successfully integrated the changed behavior into their lives, and there's no desire to return to previous negative behaviors. Understanding these stages can significantly impact how we approach behavior change interventions and support individuals in making sustainable changes. Today, we have covered many key points. We discussed aspirin's benefits and risks in preventing cardiovascular disease, stressing personalized decision-making, cholesterol management and strategies, including lifestyle changes, medications, and regular checkups. We talked about how patient education empowers informed decision-making, while shared decision-making fosters collaboration. The readiness to change model, or the TTM model, and how that emphasizes recognizing and supporting patients at their readiness stage. Remember, ultimately, our goal is to empower patients for better health outcomes. I just want to thank you all for your time and your dedication to patient-centered care. And let's continue working together. And with that, I am going to open it up for questions. See if anybody in the group has any questions. Quiet group. No questions. Okay. I know it was a lot of review. So with that, I'm going to, since I'm not hearing any questions, I'm going to move forward with our last couple of polling questions. And so if Jerry or Carrie, if one of you could please bring up the polling question number 1. The question is, I learned something useful in this session, and yes, I'm going to put it into practice and share it with colleagues, or no, this is something I will not use in practice or share with colleagues. If you all could please answer that and submit your answers to your questions, that would be great. Okay, we got one yes. I'm going to put it into practice and share it with colleagues. Thank you. And then our second polling question. we could bring up our second polling question, which is overall, how satisfied were you with the information provided during today's webinar? 1, very satisfied, 2, satisfied, 3, partly satisfied, 4, not satisfied. You all could please answer that one. Looks like we have at least one person that answered. Oh, so we have a very satisfied at 50%, a satisfied at 25%, and a partially satisfied at 25%. Well, thank you all for responding to that. I do want to share that we have some different various resources available to you at the end of the slides. There's a page of aspirin resources and 2 pages of cholesterol resources. I do want to also remind you that we went over this at the very beginning, but the collaborative schedule for the next couple of collaborative meetings are May 7th, where we're going to cover tobacco cessation, June 4th, where we're going to cover cardiac rehab. Again, those are the first Tuesday of the month, and they are from noon to 1 o'clock Central Time and 1 to 2 o'clock Eastern Time. And then also remind you that you can continue this conversation and receive all of our resources in the Superior Health Connect. Remember, Connect is a shared learning environment for Superior Health participants to come together and to foster and promote an all teach, all learn climate that provides the framework to improve and sustain mutual health care quality improvement initiatives locally, regionally, and nationally. And lastly, we have a new thing available for folks to sign up for. Superior Health is offering another service. We are offering an on-site free mobile vaccination clinic and health fair, where we will have such things as a COVID-19 vaccination clinic with healthcare education topics, including self-measured blood pressure, chronic kidney disease, safe opioid use and substance use disorders and stigma, dietary resources such as CKD, DASH, diet and diabetes, cancer screenings, mobility resources and falls, tobacco cessation, and more. If you are interested in this, you can contact the email on the slide here, immunizations@superiorhealthqa.org, and get your health fair request started today. Again, thank you all for joining us, and we'll see you next time.